evening, everyone.
Good evening, madam.
Yeah, I'll take this opportunity to first congratulate Dr. Yogesh sir and Dr. Nehal
Yeah,
for
madam.
being in the new team of the Central IIP. And of course, our academic guru, Dr. Prajapati sir. We have been missing you on few of the previous occasions, sir. So I would like to ask Dr. Yogesh sir if he would like to talk to the viewers today.
Thank you, madam. My throat is not
All right,
good.
you're not
So
well.
please go ahead because I'm
Okay,
speaking.
all
Just
right.
now I finished the one Zoom meeting.
Okay, sure. Dr. Nehal, you want to give any inputs?
No, thank you, ma'am, for sparing Yogesh sir because he need to speak so many things on
The
Tuesday.
other
That's why.
meetings. All right. Okay. Dr. Prajapati sir, with your permission, then can we start with the session?
Please, madam.
Yeah. So let me first introduce our two experts. It's a neurology case that we are going to discuss, interact, and learn from each other. So we have Dr. Sandeep Patil. He is one of the alumni of BJ Government Medical College, Pune, a very bright resident, and now he has taken up neurology as his field of expertise. He is trained in epilepsy as well as epileptic surgery, and he is practicing at Dinanath Mangeshkar Hospital. Academic as well as non-academic, lot of activities he does, trekking, etc. And mainly his field of expertise is epileptic disorders, which are difficult to treat. And he has ventured into the treatment of surgical use of treating these refractory cases. He's had various publications in national and international journals, as well as he has received awards for his presentations at various conferences. And he also is one of the founder members of a youth wing. Maybe later on we can talk to him, where sports activities and extracurricular activities, keeping yourself fit, is what they do in that particular league. So welcome, Sandeep, to this session, and I'm sure our residents and all the
Madam
viewers will learn. Yes, sir. You would like to say anything, Dr. Yogesh, sir?
No, madam. I thought your connection was poor.
Poor, yeah? Okay. Yeah. Can you hear me now?
Yeah.
I
Okay,
think Dr. Thawal is another expert.
Yes, Dr. Dhaval Solanki is also with us, another young dynamic epilepsy expert, and venturing more. He's more interested in neonatal neurology, I gather, Dr. Dhaval, from your CV, which I was going through. He's also trained in epilepsy as well as the neurological disorders with an interest in GBS as well. And Dr. Dhaval is practicing in Bhavnagar. He's as a pediatric neurologist over there. He's a very dynamic young person making into the neonatal neurology now. So welcome, Dr. Solanki. And I'm sure you and Dr. Sandeep, both of you, will take us through some newer advances as well as the basics, which we always learn from Dr. Prajapati sir. As far as the team who is presenting today, we have two of our junior residents who are year 3, JR3, Dr. Aishwarya and Dr. Divya. They will be taking turns to present the case, and they have been mentored by Dr. Uday Rajput, who is our senior associate professor and also a national trainer in BLS PALS, and has established a training center in BJ Medical College, and also looks after the pediatric ICU, and a good administrator, I can say. So welcome, Dr. Uday, and also all the best, Dr. Divya and Aishwarya. Do present the case the way you do on the rounds. And I'm sure you will learn a lot from the two experts, Dr. Prajapati sir, Dr. Nehal, and Dr. Yogesh. So I hand over now to Dr. Aishwarya and Dr. Divya. Rupsa, if you can share their screen, then they can get going.
Good evening, everyone. Our patient, 9 years old female child, resident of Hadapsar, Pune, born of non-consanguineous marriage, belonging to Hindu community, second by birth order, history which is reliable and adequate, came with chief complaints of difficulty in walking since 4 years and now not able to walk properly with loss of balance and frequent falls since 3 years. Difficulty in speaking since 4 years. History of present illness. Child was apparently all right 4 years back when mother noticed patient was tripping her legs while walking without pain, which was gradual in onset, progressive in nature, like earlier patient was able to do daily activities and go upstairs on her own and now progressed to an extent where she is able to walk only with support. Child was not able to stand and was swaying and falling on the right side even with eyes open and closed. On further asking the mother also gave history of difficulty in wearing slippers in the right foot and she noticed thinning of muscles in the right foot. Child was able to speak normally till 4 years of age. Then mother noticed patient is having difficulty in speaking, such as initially she started speaking in slow speed and later progressed to an extent where she was not able to complete the entire sentence and then started taking pauses in between words. Later, there was slurring of speech but was able to comprehend the content of speech. Mother also noticed the patient started forgetting things like earlier she was able to recall the things happened in school, but now she is not. She also has intermittent inappropriate laughter episodes. She is able to raise her hand above head and comb, but with difficulty. She has difficulty in drinking milk from cup. No history of seizures, altered consciousness, no history of involuntary movements, no history of loss of smell sensation, no history of visual disturbances, hearing disturbances, no history of loss of sensation on face, loss of taste sensation, no history of deviation of mouth, drooling of saliva, no history of spinning sensation, no history of regurgitation of food. Child is able to appreciate cold, warm, pain, and touch sensations. No history of sleep disturbances, bladder bobble disturbances, no history of abnormal eye movement, no history of fever, headache, blurring of vision, no history of rash, no history of waxing and waning of symptoms, and no history of trauma.
Okay, can you just stop sharing for a while?
Yes.
I think Dr. Aishwarya is sharing the screen. Dr. Aishwarya or Dr. Divya?
Yes.
Aishwarya.
Aishwarya.
Okay, so that I can address properly. I think so many negative points she described. For a minute, forget the negative points. Focus on the complaints. As she said that 9 years old female patient has presented. And the problem is since the age of 4 years. Am I right, Dr. Aishwarya?
Since last 4 years, age of
Since
5.
last 4 years. That means started from the age of 5 years.
Yes.
Okay. And then when we she described the difficulty in walking, frequent falls, even the later on difficulty in wearing the slippers or maintaining, able to even raise the hands, but difficulty in combing and other activities, what describes she. And second complaint regarding the speech. But I think we'll take one by one. Anybody can take that with all this difficulty, weakness or walking or all the narration what is given, what does it suggest? What type the problem is likely? Anybody can take it. I hope that other students are also there on the screen.
Yes, sir.
Madam, just can you?
Ashish is there.
Yeah.
Ajin is there. Hamir.
Okay.
And Rajat is.
And I request all the students that please participate in the discussion. Whatever you understand, no problem. I think here nobody's clear. Even somebody asked me, I'm not clear that where's the problem. But I'm sure that the way in which we can at least try to understand, we'll be able to reach the problem. We'll take it. First, I think others, then last Aishwarya and Divya, they must have come with some preparations. All of us are without any idea. So let us go. And ultimately, at last, we'll go to the experts. Rajat, can you take it? I hope that you have heard the story, initial story of illness.
Yes, sir. Uh, so looking at the history, it mainly points towards a peripheral neuropathy with distal weakness more than the proximal. And also there is a history of difficulty in wearing sleeping of the sleepers. So kind of a joint position, vibration sense and proprioception issues. And a glove in a stock type of sensations with difficulty in the distal muscles of the feet and the hands.
Okay, I think Rajat has strike on an appropriate point. If we put the points together, that mainly difficulty in wearing the sleepers or even combing, if you focus to these complaints, it indicates that the problem, whatever it is, that weakness or motor weakness started from the distal parts. And if really if our interpretation is right, of course, we understand that may be related to some peripheral nerve problem that we can understand. Let us see at least with the preliminary understanding. Okay, but at the same time, Rajat, if you look at other complaint, that is a speech problem. Even later on, she added that there is a problem of even the memory also. Even so many other issues also she described. If you put these points together, probably does not explain only this peripheral, nerve problem also. Probably it is beyond that. And what does it indicate? Anybody else, or Rajat, you can take it with the continuation of your previous discussion?
Sir, we can consider that the lesions are disseminated.
Rajat, I think your voice, can you adjust with your mic somehow?
Yes. Sir, am I clear now?
Yeah, it is clear, but probably the volume is low. So probably you may be away from mic or so. Just you can adjust so that all people can attend you.
Yes, sir.
Okay.
So since we can consider that the lesion is disseminated in space, like there are various issues which are occurring. It can be one possibility can be a demyelinating lesion.
Okay. I think all of you know that in neurology, as such, not in neurology, but any system, always we are trying to look at the anatomy. That where is the problem first? And from anatomy, we can give the thoughts for the pathology. Probably from the history, etiology may not be possible, except very few conditions. So I think here, if you see this, whether it is the peripheral nervous system problem or central also, Rajat, what is your idea?
So involvement of the cortical as well as peripheral issue.
Okay, that means both the components of the nervous system are affected. How
Yes.
will you take the problem with the speech?
So speech, the exact in the history of speech, the exact defect in the speech where it is whether the child is able to comprehend, not comprehend, or whether there's a difficulty in the output, the speech output is affected. That we are not sure, sir. Like what component of the speech is mainly involved?
Anybody else would like to? I think first students. Any other students?
Dr. Ashish is there.
Yes, Dr.
Hamid,
Ashish, please.
I can
Beyond, I
see.
think what Rajat discussed, if you want to add something of your interpretation is something different, I think Dr. Srishti.
Rushti Dimple is there.
Uh,
Dr.
Dimple,
Malik.
please.
Anybody who wants to add to the speech problem of this big child?
I think prerequisition of learning is the participation. We'll have to speak, which may be right or wrong, but at least whatever our understanding, we can try to put it. Okay, Aishwarya, what is your understanding? Because I think you described mainly three problems. One is the motor problem, that is regarding the weakness. Second, you said probably focus mainly on the speech problem. Third, probably memory and other aspects are also involved. Now, each component, how you are taking that, which part of the nervous system is affected. First, let us focus on the anatomy.
So the patient is not able to walk, and there is history of frequent falls. So there can be the cortical involvement, but in a cortical involvement there will be upper motor neuron lesion. So there will be spasticity, and the tone will be increased. But in this case, the mother is giving history of swaying on the right side. So it is more towards the cerebellum, like the patient is not able to stand straight, and there is difficulty in coordination. And the second point was the patient was not able to wear slippers in the right foot, and the mother also noticed thinning. So there may be some peripheral neuropathy involving the right foot. And for speech, sir, the patient is able to comprehend, and she is also understanding what the questions are asked to her. So the Wernicke is working, and she is also able to respond properly. So Broca's is also working. There is some difficulty in output of the speech. The words she's saying, there is slurring of speech, there is pauses in between the speech. So probably there is dysarthria, there is no proper articulation of speech.
Very good. And what is regarding the memory?
Sir, when mother was telling, she's able to give history of like the last meal she ate, but she was not able to tell the things she did in school. So mostly the remote memory is affected. So can be the hippocampus or the prefrontal lobule affection.
Okay. I think before we go further, let us try to know from the expert. Dr. Sandeep, can you take it? That how we should try to analyze the problems described by her.
Okay, first of all, I would like to congratulate Shweta, right? So Shweta for taken good history and
Aishwarya.
okay.
Aishwarya.
Sorry.
Aishwarya.
Yeah.
Aishwarya and Divya.
Aishwarya, thanks for taking the good history. But this history, see, as a student, I think when we are localizing a neurological case, there are two important aspects. One is a timeline. Okay, so in a neurology, what is important is the when the symptoms first started and how it progressed. So, and obviously in any history it is very important, but in neurology it is very important because whether you are looking at acute presentation, subacute presentation, or chronic presentation. So in your history, it is a 4-year duration, right? So it is kind of a progressive disorder which is going on slowly for last 4 years. So that gives me a perspective that it could be a chronic condition which is kind of progressive in a nature, because the history and timeline you have given me, so it kind of a progressive disorder. So it gives you the kind of information about etiology. So what kind of etiology you are looking at, right? Then it's always better to dissect out neurological symptoms, right? So that will give you the systems which are involved. And then, as Dr. Prajapati said, localization. So we will go by symptoms. And first symptom was difficulty in walking, right? Tripping her leg. And you mentioned that it was a gradual onset, it is a progressive in nature, initially she was not able to walk upstairs, and then she then had a difficulty which is progress further. Okay, so it tells me two things. One is it is like a gradual progressive disorder and involve proximal muscle first. Okay, so the proximal muscles are useful to climb the stairs, or getting up from sitting and squatting position. And then you also mentioned that progressively she had a difficulty in wearing the slippers. Okay, and also notice that thinning of the muscles. So if I go timeline wise, it is a proximal muscle involvement first, and then the distal muscle involvement, and then probably thinning, which tells us atrophy. So this is about a motor system which you have talk about. Okay. Then the second symptom what you have mentioned is difficulty, like while standing, the child is swaying to the right side. Okay, so that again falls into the category of imbalance while standing or walking. So the imbalance, there are two systems which are involved in a balancing the things. One is a posterior cord, where you have the sensations, dorsal column tract which is there, and you are aware of the surrounding. And then the second is cerebellum. Okay, so I don't want to, emphasize that probably it is a cerebellar disorder or anything, but at the history point of view, I just want to enumerate what are the systems which get involved. Okay, so here I would say probably cerebellum may be involved, plus maybe posterior column also I need to look into, if at all, that will confirm on examination. Hmm? Not everything you have to confirm on a history. On a history, your hypothesis should be wide enough so that you can focus every system which is involved. Then the next thing you mentioned was about speech. Okay. Again, the speech, there are few things which we need to address, whether it is a aphasia or it is just a motor issue. Okay, or it is the issues with understanding, and whether the pitch, how was the pitch, high pitch speech or low pitch speech. So whatever you mentioned, it felt like there is a slurring of speech, and it is more like a motor issue. Again, if you get into the tripping of legs, so the spasticity kind of thing which can brings a tripping and slurring of speech. So again, what it tells us that it is a upper motor neuron lesion, probably spastic, or as you said, swaying on a one side could be cerebellum. Okay, so what I am looking into is more of upper motor neuron lesion involving cortex or cerebellum. That again we need to look into when we do the detailed examination. And the last thing what you mentioned is about memory. Okay, so that she's forgetting the things, and she's not able to recall. Also, she had some behavioral issue with inappropriate laughter, what you mentioned. So overall, the flavor, what I feel is more of a upper motor neuron condition, which is probably involving multiple systems, motor as well as coordination, also has impact on speech and memory. So if it is a progressive disorder involving speech and memory, so probably what we may look at gray matter disorders, which can present like this. Again, this is a broader kind of concept which we need to zero down with our further negative history and examination. So these are the thoughts which comes to my mind. I think Dhaval can add few more.
Well,
Think so. I'm agree with the Prajapati sir as well as with Sandeep. Okay, we are dealing with the CNS disorder involving the cortex, cerebellum, as well as we have a component of peripheral nervous system. Okay, so as of now, by looking to the origin, duration, and progress, we are dealing with the progressive neurodegenerative disorder that keep in our mind. But there are certain things that may be treatable. So in negative history, rather than asking the so many negative history, you just ask the treatable cause. like certain vitamin deficiency leads to such type of symptoms. Keep in your mind. Okay, nutritional aspect is very important in your PG exam. Okay, so that highlight us in the origin duration progression. There is no other skin disorder, skin features, or vitamin deficiency feature that leads to certain features. As Dr. Sandeep says, okay, we have to look into the posterior column, dorsal column. So vitamin B12 in our mind. You have to think about vitamin E deficiency that also leads to cortex involvement, posterior cord involvement, cerebellum involvement, as well as the PNS. Okay, so that I want to add. Otherwise, there are so many neurogenetic and neurodegenerative disorder. We look into the examination.
Fantastic. I think the message for the students that never fix up your mind for some disease or some etiology. I think as a clinician, we should keep our mind open and think the various situations. Second thing in the neurology, more, I will say in any clinical examination, clinical case, but more so in the neurology, use the multiple adjectives. When you are describing, suppose in the conclusion, here I think we can say that the span of the illness is more than 4 years. So it must be, we can say that it's a chronic disease. Second thing, you can say that it is an insidious onset. It has not suddenly started within few hours, days, or weeks even. So we can say that the insidious onset, chronic disease, it is progressive in nature, right? That is the pattern of the disease, involving multiple, I will say, aspects or the components of the nervous system. Of course, if you go for the involvement of speech, memory, some even emotional outburst, it indicates that the probably this is with a cortical involvement, various parts of the cortex. Generally, we will keep the open. Second, very appropriately, that regarding this, even the locomotor involvement, if you focus, it indicates that the more of the cerebellum pattern. And of course, the other features which we discuss, that peripheral nervous system is also not spared. So in short, multiple components of CNS is involved, insidious onset, slowly, gradually progressive in nature, involving multiple components of the nervous system, and that various regions can be there. I think very difficult to decide this etiology or even the specific pathology from this, which can be, at least we can say that less likely the vascular, less possible even the inflammation or any infective, because that story will be of different variety. So more, what does it suggest? That either some degenerative disorder or probably some deficiency gradually increasing and involving the nervous system. Of course, with that, in the nutritional problem, other systems will also be involved. Probably may not be obvious in the history. Once you go in the examination, you may get some evidences of, I will say, nutritional disorders also. So I think that's the thing, that how we can keep it open. The only thing, in the negative history, please don't go for the very long list. That decreases the value of our history. Maybe here what you want, I understand the apprehension of the students, that relevant every condition should be ruled out or considered. I think that's not the right approach. Of course, your apprehension is there, but related to your case, which probably strengthens our possibility or excludes the nearby differentials or some expected complication, whether they are present or absent. I think related points should be mentioned in the negative. Everything in the neurology we cannot exclude by the negative points, right? So I think our attempt should not be like that for the negative points. Make it, I will say, comprehensive, very few points, very related, nearby to your condition. I think that's a point which we can keep in mind. Should we go further in the history, madam?
Yes, sir, definitely.
Okay, so Aishwarya and Divya, both of you can share your PPT again and go ahead.
Yes, sir. Past history. Child was taken to some Ayurvedic hospital for same complaints and took treatment but stopped on its own as no improvement was seen in symptoms. No history of repeated infections in the past. Family history. There is no history of similar complaints in the family. No history of TB in the family. Birth history. No significant history in prenatal, antenatal, natal, and postnatal history. Developmental history. Patient had normal development up to 4 years of age, but from the history given by the mother, there was variable regression of the achieved milestones. The maximally affected was the gross motor, followed by fine motor, and then least affected were the language and the social. So impression is that there was regression of the achieved milestones. Dietary history, there was a 8 gram deficit of proteins and 420 kilocalorie deficit in calories. Immunization history, child is immunized till age of 5 years. Last vaccine taken were DPT booster, OPV booster, vitamin A as per universal immunization program. Socioeconomic history, the family consists of 4 members with the head of the family income was 15,000 per minute per month belonging to MK's class 4 upper lower. Summary. Our patient, 9 years old, female child, born of non-consanguineous marriage, came with complaints of difficulty in walking since 4 years, which was gradual in onset and progressed to an extent where she was not able to walk without support with wasting of right foot muscles. With difficulty in speaking, which was gradual in onset and progressed to an extent where she couldn't complete her sentences with slurring of speech. She is having memory problem and behavioral problem with regression of achieved milestones. So the most probably system involved is central nervous system, and for the microanatomical localization, the most probably cortex is involved because on history there is behavioral and memory affection, cerebellum because there is coordination difficulty in walking and speech, and peripheral nervous system because there is wasting of muscles and inability to wear slippers. For etiology, it is most probably degenerative because the history is chronic and progressive, and there is regression of the achieved milestones. From history, there is no sign of any complications.
Ishwara, you have the examination findings?
Yes.
sir.
I think before you go for the examination, can we just again stop for a
Yes.
while? I think now she has given some more points in the history. With that, what we'll try to make the hypothesis. It is very clear that from the history, we cannot give the diagnosis. We can prepare some platform, some hypothesis that what type of the disorder it is. Is it really traumatic, having some congenital problem, inflammation, infection, any space occupying lesion, degenerative, which even degenerative component, like that we can give the thoughts with this history. So who will take it that now, what is our inference from the information which is provided to us? Who will take it? Dr. Dimpal, can you take it? I think all the names are there, but their video is off. I do not know why the
And
students
we
are
will
kicking
have to
themselves away.
ask them to switch on their videos so that we know who's who.
Yeah.
Akku, you want to add something, or Augustine is here? Shushti?
Sushti, please come on. Whatever points in your mind, already I would say experts have given some ideas to us. You can further elaborate. Even presenters had also given the good background, some clarity on the history. Rajat, what is your interpretation?
So most likely it looks like a degenerative disorder.
Okay. Right,
because so first thing is the insidious onset chronically progressive
okay.
in there's involvement of multiple systems like cortical function, the cerebellar function, the peripheral nerve involvement.
I think the point is very specific characteristic of the degenerative to say.
Uh, so the regression of the attained milestones which have occurred.
Okay.
Dr. Aishwarya has given you a history of vaccination.
Yeah.
Is there any relationship to vaccination in such type of presentation? May not be exactly, but what is it? Or something in the history they could have asked the mother.
History of measles could have been maybe asked.
Yes. Yeah, why do you want to know that?
It can present like SSP. That also can present like neurodegeneration.
Okay.
Yes. Okay. So what about the vaccination? No measles, no skin rash, nothing. Mother doesn't remember. But she says she has given some vaccines. Augustine, can that same presentation be there with vaccinations?
Such a chronic history, I'm not able to think of anything, man. If it was acute, then maybe not very sure about.
What do vaccines cause and to give rise to such problems, though very, very rare? Not very common.
I think the exam
Okay.
sometimes it may happen. So as Madam started, that another exam may be tempted to ask you the question that what are the neurological complications related to the various vaccines? Forget regarding our case. We are not discussing with reference to our case. But the exam, some examiner may ask that what are the known neurological complications following various vaccines. Let us try to learn, I will say, whether it is there in our patient or it's a different story. Who will take it? I think let other students come on. Dr. Shrusti or another person is there.
Dr. Malik.
Hamid. Please keep your video on at least. You may not speak anything, no problem. Nobody is going to force you to speak. Even you know that in the democratic country, that is the more safety. Even if you speak something, then also nobody can prevent you.
We don't want a definite answer. You may be wrong also. Nobody is going to criticize or make fun of
Dr.
you.
Divya, can you take it? What are the neurological complications following various vaccines?
Yes, sir. Yes, sir. Actually, following by influenza vaccine, polio vaccine, and rabies vaccine, someone can have GBS, Guillain-Barré syndrome.
Okay.
And after rabies and OPV also, they can have transverse myelitis also.
Absolutely.
And, in some cases, after hepatitis B, they can get multiple sclerosis. I've read. And Japanese encephalitis. After Japanese encephalitis, it was recorded that Adam was there.
Right.
Apart from this, the infections will cause neurological damage. There are two infections.
એને તમારા ઘરમાં કોઈને બીડી બીડી પીએ છે કોઈ ઘરમાં ચૂલો
Yes. I think Dr. Srishti was taking the history with some other patient. Any problem with the DPT vaccine?
As pertussis wholesale vaccine, that pertussis component can cause it.
What problem? CNS complication?
Progressive encephalomyelitis. Like
Simple, I will say pertussis encephalopathy.
yes,
Pertussis encephalopathy is known.
yes, sir.
Of course, even polio, oral polio vaccine can cause this VAP, acute acid paralysis, right? So the point is actually some aseptic meningitis with various vaccines are also known, viral, even the mumps and rubella and others. Anyway, so these are the problems which at least we can keep in mind, but they are very rare. So I think we may not highlight, and they are not probably much problematic to prevent the vaccination. So our discussion should not discourage the vaccination. That's the point. Just only you can keep the points in your mind. Okay, I think somebody said degenerative disorder with this regression of the milestone. I think Aishwarya herself should describe regression of milestone. Aishwarya, I will say it is a pseudo regression. I think due to this illness, the regression is there. It is not the true neurological regression. What is your stand?
Yes, sir. Because
Or,
of
or in other way, can you explain what is the pseudo regression? Somebody is going to ask in the exam.
so the regression because of the weakness or the incoordination. That's why she's not able to do the activities.
Again, your volume is not proper. Can you adjust your mic, please?
Go close to the mic.
Yes. Sir, the patient may not be able to do the activities because of the weakness or the incoordination, and not the because of the some neurological regression. The weakness is not letting the patient do the activities.
Can you give some example, easy to understand, where the regression is there, but it is a pseudo regression?
IM after any IM injection, the patient can not be able to walk. But not it's like regression. It is because of that problem, traumatic neuritis.
Maybe I think that is a misinterpretation. After following the injection, probably some reason is there for not walking. There is no regression. What we mean by the regression? That child develops some milestones, but later on, there is some loss of these achieved milestone. And basically, if you go in the details, it is not due to the neurological problem, but some other component or some other illness may be responsible for the loss of these achieved milestones. And then we realize that this is the pseudo regression. And probably with the treatment of that condition, again, child is able to achieve the lost milestones. That's, I will say, meaning what we say, the pseudo regression. With that reference, severe acute malnutrition, very simple to remember. That mainly the motor milestones are lost. The child was able to walk, but again stopped to walk, or even able not sitting. Following probably correction of the nutrition, again child is able to do, and continuing the development its own way. And that's why in between what we observe, we say it is a pseudo regression, right? Similarity happens in a case of cerebral palsy. That cerebral palsy following due to repeated epileptic episodes due to some of our drugs, right? Even the multiple anti-epileptic drugs, there may be some impairment of this achieved milestone, but in true sense, it's not the regression. So I think that we should be able to understand that what is the regression and what is the pseudo regression. Anyway, and then try to find out it is the gray matter or white matter. Initially it starts with the gray or white. Ultimately, both the components are involved. Then very difficult to differentiate. But if you go in the details of the history, that how it started, what was the first component, that will give you the idea, even to identify the pattern or the disorders of the regression, right? So I think that's the thing, that how we can take it. Suppose here, if you consider that there is a regression, what type of the problem it is? What does it indicate? Degeneration, degenerative disorders, which we say, can happen due to the several reasons. Among all the various reasons, What is likely in our case?
What sir is asking is the pathological changes
Yeah.
which happen. The word degeneration means what? Is it that the cells start dying or they are replaced by something, or they lose their functions because of various deposits, or something like that you should know exactly what is the meaning of degeneration.
Apoptosis of the cells.
Apoptosis of the cells. Okay.
And
Any
it
other?
can be due to the accumulations also in white matter disorders and all. Some it's like example like MLD, metachromatic leukodystrophy. The sulfides are deposited, so they are going for the degeneration.
Anyway, I think we may not be able to give the much points on from the history. Probably on the examination will be more clear. Should we go for the examination?
Yes.
Yes,
If Dr. Dhawal and Dr. Sandeep want to add anything at this
Yes, sir.
stage,
Before we go for
because
examination.
there's a word like in the chat box, demyelination is coming repeatedly. It's not
So
degenerative
basically,
alone, demyelination. So Dr. Dhawal, please, want
yeah,
to add? Yeah.
yeah, Dr. Esoria and Nivia presented very nicely the origin, progress, and duration of the disease. And as we all in the one line, we are dealing with some neurodegenerative disorder. As of now, we don't know it is acquired, because sometimes the acquired lesions also presented like a neurodegeneration. Sometimes, as sir says, the pseudodegeneration means some acquired disease and we can treat it. Some are, as of now, not treatable, neurogenetic or neurodegenerative disorder. So, as Dr. Aarti Madam says, what is neurodegeneration? So, it is either cell dies due to accumulation of the metabolites, either the direct injury to the cell membrane, okay, and then comes the certain factors that comes, okay, between the cells, okay, and then comes the demyelination. Okay, so why demyelination is coming right now, I'm not sure why the students are taking demyelination in this picture. Okay, because history is not giving such idea, in it is not relevant to our case as of now, the demyelinating disorder. Okay, so when you think about the MS, it is very rare. They usually not present at 4 years of age. And the rest of the demyelinating disorder like ADAM, AMDAM, okay, they have acute presentations. It will not progress like that. So as of now, it is not in my mind, the demyelinating disorder. Okay. Then comes the other rare disorder that present as NMO, MOG. Okay. They also present in acute phase and there is a more involvement of the cortex. Then comes your cerebellum involvement, then the PNS involvement. So as of now, there is no history of seizures. There is no history of misbehavior disorder first. It comes last. So initially the PNS features, then cerebellar features, and then your cortex gone in ODP. So ADAM, AMDAM not presented like this. So demyelination disorder as of now, no. So we'll proceed further in examination and then conclude.
Okay. Thank you, Dr. Dhawal. Sandeep, you want anything to add or?
Yes, I'll just make a brief comment because we are come up to the examination point. First of all, when you're taken the history, the next part is the negative history, and I feel that is very important part of the history because that will give you most of the things, right? So I would like to know in a negative history what are the systems which are involved. Like for example, it's so when you take a history, you make a hypothesis. For example, we are talking about degenerative disorder. We are talking about demyelinating disorder. Could be congenital disorder which is progressive, right? So I want that negative history pointers which can differentiate between these all etiological hypotheses. So for example, if I take a degenerative disorder, I want to very much know whether it's a gray matter disorder or white matter disorder. There is a reference for SSP, so vaccination, history of vaccination you're taken, so that is good. But again, you can ask different histories again, like a hearing difficulty or probably cognitive decline. Okay, so the cognitive decline, behavioral issues. So that will give you the flavor whether it's what kind of systems which are involved. We are looking at cerebellum involvement and cortical involvement. So both the things are upper motor neuron, but still you can always ask for bowel bladder habits and whether those things are involved. In a demyelination, most of the times it is kind of a waxing waning episodes. Okay, so that is very important history which we should take, whether there are periods where the child was normal and there are periods where child was not normal. And usually demyelination comes with the encephalopathy. So the encephalopathy means the brain doesn't function well, or child is kind of maybe sedated or not behaving normally in between the periods of sorry, my phone just so periods of normal behavior and then abnormal behavior. So again, so negative history is very much important. Sorry again. So negative history is very much important for me. And then if I rule out certain disorder, okay, in a degenerative disorder, you need to know what are the disorder you're looking at. Okay, whether you're looking at storage disorder. So the storage disorder also can come. So visual difficulty is a very important negative history. Okay, so for example, you are thinking like a progressive myoclonic ataxia or NCL, neuronal ceroid lipofuscinosis. So they will come with a visual difficulty, then ataxia, then they very much can have fall also. They can sway also, right? So this can fit into your picture actually. Okay, and they can have cognitive decline also, means memory issues also, speech issues also. So that is very much important. Okay, so hearing difficulty, vision difficulty, that I need to know. And then obviously waxing waning course, that is the important thing which we need to know. As Dhaval mentioned, there are some demyelinating disorder which can come like demyelination per se is acute. Okay, so you get post-infectious, post-vaccination, acute demyelination. But in some demyelination, the course can go on for years. So remitting, relapsing kind of episodes. So that history also should be there. And obviously you can then go into the examination and find out what are the things from your history are matching with the examination. Okay. Yeah, that's it.
One thing which I wanted to add, y'all did the presentation with the nutrition history. You just said calories and proteins. Dr. Dhaval sir has said that there could be nutritional issues. So in such cases, you can take the actual diet, consumption of which type of foods will cause deficiency of B complex, vitamin C, and all that group. So you can go into a little bit more detail. You can present as calories and all, but if you find that the child definitely is a vegetarian, not eating any green leafy vegetables, no citrus foods, etc. So, and of course, the nutritional status we will come in the examination. But you all know the case before us. Okay, you have made a diagnosis. Then you retrospectively try to fit your history, which you have taken, and put it over there so that you can make use of that deficiency of vitamins and micronutrients. We talk only of the macronutrients. If possible, take a history of the other aspects. Okay. So we can proceed, sir.
Yes,
Dr. Uday is here. If your students are missing something, you can of course add over there. Okay.
Yes, madam.
All right. Yeah. So we can go ahead, sir. You want to present the findings now?
No, examination.
Share the screen.
Yes, ma'am.
Going for the examination, anthropometry, the weight of the child is 25 kg and the height is 132 centimeter. BMI is 14.7, which is normal for the age and sex. On general examination, the child is active, playful, lying on bed comfortably, afebrile, pulse rate 98 beats per minute, regular rhythm, normal volume, no radiofemoral delay, and all the peripheral and central pulses were well felt. Respiratory rate 20 beats per minute, regular, abdominal thoracic, BP 100 by 64 millimeter mercury, which falls to the 50th to 90th centile, measured in the supine position and in the right upper arm. SpO2 98% under room air. There is no pallor, no icterus, no cyanosis, no clubbing, and no pedal edema. Going for the head to toe examination, head shape is normal, eyes normal, there is no squint, and poor dentition is present. The teeth are malaligned, and there is wasting of right tena muscles present, and wasting of medial plantar arch muscles of the right foot also present. The picture showing this. And on lying supine and in bed, right foot is externally rotated here, and no signs of micronutrition deficiency, that is vitamin B12, B6, B1, and vitamin E deficiencies were present. Genitals normal, spine normal, no neurocutaneous markers present. Systemic examination, central nervous system, child is supine position, comfortably, decubitus, the child is lying in supine position comfortably with the right foot externally rotated. Going for the higher mental function test, child is conscious, oriented, playful, and active. Patient's immediate and recent memory is intact, but the remote memory is not intact because she is not able to recall the things happened and in the school or last 1 year, last 2 years. Speech comprehension is present and the motor or speech is good. But the fluency is reduced. The child can repeat the word. There is staccato scanning speech is present. Gait, while walking, the child swaying on the right side, probably ataxic gait. On cranial nerve examination, there is no signs of cranial nerve involvement. And fundus examination, normal. Motor functions, muscle bulk, bilateral upper limb muscle bulk were normal, except there is wasting seen in right tena muscles, and bilateral lower limb muscle bulk were normal, except there is wasting seen in right medial plantar surface. Examination of the tone on bilateral upper limbs, the tone is normal, and bilateral lower limb, there is spasticity. And power examination in the upper limb, shoulder joint, elbow joint, and the wrist joint, and bilateral right and left, the power is 4/5, and lower limb, the hip joint, knee joint, and the ankle joint, and the power is also 4/5. Going for the reflexes, while examining the superficial reflexes like cardial, conjunctival, abdominal, all are normal. Bilateral plantar reflex, which is extensor, that means the Babinski sign is positive. Examining the deep tendon reflexes, bilateral knee jerk and bilateral ankle jerk were exaggerated. Other jerks are normal. Sensory system examination and normal. Here, this video showing how the knee jerk is exaggerated. And in this video, the gait of the child is shown where she is swaying on the right side. cerebellar functions, head and neck, there is no titubation, there is no nystagmus. On upper limb, finger nose test, finger test, there is pause pointing thing while the child is doing this. That means dysmetria is present. And this didacokinesia is present because the child is doing the alternate supination and pronation slowly. Rebound phenomenon absent. On lower limbs, gait, while the child is walking, swaying on the right side. And Rombock sign and the tandem walking were abnormal because the child is swaying on the right side even with the eyes opened, and she does the same in the eyes closed also. Heel to knee test performed with difficulty. Pendular knee jerk absent. Autonomic functions normal. And there is no meningeal irritation signs. The skull and spine were normal. And this video showing the truncal ataxia of the child. And this video showing the finger test where there is the child is not able to pick up the speed and the meter distance of the finger, and also there is pause pointing in the target. And here this didacokinesia is present. And other system examination, cardiovascular system, respiratory system, and GIT were normal. Going for the summary, our 9-year-old child came with the complaints of difficulty in walking and difficulty in speech since 4 years, with memory and behavioral problems, with regression of achieved milestones. After examination, we conclude that the system involved is central nervous system, and the microanatomy affected are 3, which are cortex, cerebellum, and the peripheral nervous system. Cortex, why it is cortex? Because there is behavioral problems and memory problems in the history also, and we have confirmed it in the examination also. And there is bilateral spasticity of the lower limbs present with exaggerated reflexes, which is more favoring for cortical involvement. And second one, cerebellum. Why it is cerebellum? Because coordination difficulty in walking and speech also present, and the cerebellar signs are positive like finger nose finger test, and there is truncal ataxia, all favoring for the cerebellum involvement. And peripheral nervous system. Why it is peripheral nervous system? Because there is visible wasting present in the upper limb, that is right thenar muscles and the right medial plantar surface muscles also. And she was unable to wear slippers. So it is mostly favoring of peripheral nervous system. With this, I'm going to discuss the etiology. Most probably it is degenerative. It can be nutritional, and it can be autoimmune or demyelinating, or it can be infection, or it can be neoplastic. But the first etiology most probably is degenerative because the condition is chronic, progressive, and there is regression of achieved milestones also present. And nutritional, why it is nutritional? Well, in some nutritional deficiency, like there will be muscle weakness, ataxia, all will be present. But in this child, there is no dryness of skin or loss of hair or any growth reduction, and or any bone abnormality is not present. So the second one we are considering nutritional. The third one is autoimmune and demyelinating. Here, there is no waxing and waning of symptoms are present. There is no ocular involvement, and there is no seizures. There is no altered sensorium also for this case. And infection, mostly it won't be the infection because there is no fever, rash, there is no acute onset in this case. And the last one is neoplastic. Like, it could be, but it is, in this case, it is not fast progressing and there is no increased ICP signs were present. With this, I would like to give my differential diagnosis. In this degenerative etiology, the first one is spinocerebellar ataxia, the second one is Friedreich's ataxia, the third one is ataxia telangiectasia, and the fourth one is metachromatic leukodystrophy. And I'd like to explain why it should be. Spinocerebellar ataxia, there are three components, the cerebellum, cortex, and the peripheral nerves. All the systems are involved. And there are more than 48 types of spinocerebellar ataxia are present. So some are autosomal recessive, autosomal dominant, and some of them are sporadic also. So in this, there is no family history with the child. And so I'd like to give the first diagnosis, that one. And Friedreich's ataxia, the same presentation will come in Friedreich's ataxia, but not favoring points. The child is not having the family history, and the child is not having any hearing problems, and the child is not having any scoliosis, kyphosis, or pes cavus. The third part, ataxia telangiectasia, the ataxia is there, but another one, ataxia telangiectasia, that should be telangiectasia with oculomotor apraxia should be present. But for this child, it is not present. The eyes are normal, all the movement of the eyes are normal. And in ataxia telangiectasia, there will be repeated infection due to immunodeficiency will be present. And this child doesn't have that to tell it is ataxia telangiectasia. And the last one is metachromatic leukodystrophy. It can be a metachromatic leukodystrophy, but for that, the child is not having any seizures, and the child is not having any optic atrophy features. So it is my last diagnosis. And for the nutritional, I would like to give differentials: vitamin E deficiency, copper deficiency, and vitamin B12 deficiency. And in the toxicity, I'll give the diagnosis for Wilson's disease. In vitamin E deficiency, the same presentation will be present, but there will be markers for vitamin E deficiency like hair loss, dryness of the skin, and all could be present. And but only muscle weakness and ataxia is present for our child. In copper deficiency, there will be some amount of anemia, and there will be growth retardation with arthritis or bone abnormalities also present. And for our child, that deficiency signs are not there. And in vitamin B12 deficiency, there is no signs of vitamin B12 deficiency, that like anemia, cheilitis, and glossitis, and any pigmentation of the knuckles are not there. And also in vitamin B12 deficiency, there must be sensory loss with the peripheral neuropathy, but our child doesn't have that. And Wilson's toxicity, it may be our diagnosis, but in Wilson's, they will present with hepatitis and hepatic encephalopathy features, as then they're going for the degenerative parts. So the presentation of our child is not like that. Here we are discussing the
Dr. Divya, can you go in all the details later on?
Yes, sir. Yes, sir.
I'm sure you must have come with lots of literature, but let us learn from
Yes,
the
sir.
expert how to go for this case in the exam like presentation. For a while, just can you stop sharing?
Yes, sir.
I think now Sandeep, she had given us lots of conditions. I'm sure that how much it is going to be useful to them in the exam. Can you just take in this way that from the CNS findings, let us forget regarding the various differentials, but whatever she has given the findings on CNS examination, can you take it exactly that how they should interpret and come to the conclusion?
Yeah, yes, sir, definitely. So I think the first part, what they have noticed while doing the CNS examination, the like we were discussing more about nutritional kind of things. So probably when you are looking at the knuckles and there is no hyperpigmentation. So again, that was our main hypothesis where, could it be vitamin B12 deficiency or maybe any nutritional deficiencies, any other nutritional deficiencies. So that will rule out those things when you are not having that knuckle hyperpigmentation and all. Then you what in examination you mentioned the notice there is a atrophy of the thinner hypothinner muscles and palm solar muscles as well. So that indicates there is a kind of element of peripheral neuropathy. But mind you, in a myopathy, progressive myopathy also you can get the distal muscle weakness, but that is late into the condition. Okay, so you will always have to cross check with the contralateral muscles as well as proximal and distal muscle. Okay, so whether it's a long-standing myopathy which can cause both proximal muscle weakness or just a distal muscle weakness. Okay, so that you have mentioned. Then other thing what you have noticed is there is a brisk reflexes. Okay, so the brisk reflexes tells me one thing. It is a more of a upper motor neuron lesion, right? UMN lesion, and the means it tells you that long tracts are involved. So my localization will go into the pyramidal tract. Okay, and given that history you have mentioned about the cortical involvement, could be it can start with a it's a bilaterally symmetrical uh, increased tendon reflexes. So it has to be high cervical or cerebrum. Okay, there is no atrophy as such, no weakness. Sorry, no weakness as such. Right? There was no weakness you had demonstrated. So it's more of a deep tendon reflexes which are exaggerated and then positive cerebellar signs.
But sorry to interrupt, Dr. Sandeep.
Yeah.
She had described that the upper limbs, tone, power, normal, even DT are normal.
Yeah. So it is more of
She has mainly described this spasticity
in the
and
lower limbs.
exaggerated deep tendon reflex in knee and ankle. But both upper limbs, she has described the neurologically totally normal. Then how will be able to explain this upper motor neuron type of lesion?
Yeah. So again, see, this upper motor neuron lesion can be at level of spinal cord, but again, there is no spinal level as such. Okay, so that on examination you don't have any bowel bladder involvement, and also there is no sensory involvement. It is just a motor involvement. Okay, and in lower limb also there is no weakness. Is there a weakness in lower limb?
Power grade 4.
Grade 4. Okay. So the mild weakness is there. So again, if it is a bilateral symmetrical motor involvement, then we're looking at a cord level or maybe specifically the motor neurons which are affected anywhere in this from the your internal capsule. So specifically those things which are involved through the internal capsule to the
Will it spare the upper limbs? Suppose internal capsule pyramidal tract fibers are affected. How we can explain that the both upper limbs are totally spared?
No, it cannot affect, it cannot spare the upper limb. But if it is a slowly progressive, starting with the lower limb first, and then maybe in the future it involves the upper limb. So that's one possibility. But maybe involving the cord of dorsal cord, that's a more possibility again, because there's dorsal cord which is involved and sparing the upper limb also. That can explain the motor involvement. But apart from that, it's more of a cerebellar signs which are positive. Again, if you bundle it together, then you can have that spinocerebellar tracts involvement also is a possibility, spinocerebellar tract. But the problem comes when there's speech and memory involvement. So then when speech and memory is involved, then you will have to take your lesion higher. And when you want to put together upper motor neuron, cerebellar science, speech, and memory, then it has to be some cortical or subcortical involvement, which we need to figure out. So the differentials, what you have put there, as a spinocerebellar ataxia, Friedreich ataxias. So the hereditary ataxias kind of presents with they have the mix involvement many times, like the cortical subcortical involvement and peripheral involvement. So we have many spinocerebellar ataxia which can comes with a peripheral neuropathy and can give you the mixed picture. Again, one more thing which so the tone is increased, right, in the lower limb.
Yes,
Yeah.
sir.
So the grade 4 power what they have got, it can be actually because of the spasticity also. Sometimes spasticity, because it is not clear weakness, which is grade 3 or grade 2 weakness. So the spasticity can limit the extent of the power in a lower limb also. So that element also we need to keep it in mind. So putting all together, because it can be patchy involvement, right? It has to make a sense with all symptoms we need to put together. And when we put all this together, definitely I would look into the cortical kind of thing. There is no nutritional deficiency. So our second hypothesis was a degenerative disorder, and the degenerative disorder which has a motor involvement, cerebellum involvement, speech and memory, and progressive. So definitely we're looking at, and there is no hepatosplenomegaly. So it is not like, our storage disorders. So it is not a storage disorder, and it is a degenerative disorder involving cortex, subcortical region, cerebellum. So I may favor more of a progressive ataxias. Okay, so I would just don't want to put on a spinocerebellar ataxia, but it is a progressive ataxia, hereditary, because it's childhood onset, 4 years, and slowly progressive. So I want to put it as a the ataxia, childhood onset, autosomal recessive spinocerebellar ataxia. That's a term which is the usually we use. It is a progressive ataxia, and they can have multi-axial involvement. So there are multiple variants of them, but again, clinically you can come into some hypothesis, and that has to be proven by the further investigations, right? So what is the variant and all? There is a variant of spastic ataxia. So there is a spasticity as well as ataxia. So that is also one possibility which comes to my mind.
Right.
Yeah.
Dr. Tawar?
Yeah, I'm agree with the Dr. Sandeep. We are dealing with the multi-axial involvement in the CNS. Only thing that is breaking my ODP and examination is the asymmetry. Loss of the thinner muscles in the right side, loss of atrophy in the right side. Usually the any degenerative disorder presented in a symmetrical way. Means I am expecting things in both legs. Atrophy as well as the atrophy of upper limb if it is a chronically progressive. Here again asymmetry in the spasticity. Upper limb is spare, lower limb is involved. Okay. It might be explained like that. Okay, it will gradually involve the upper limb. Okay. But down the line for 4 years, there is nothing in the left leg. No atrophy, no changes. Is there any asymmetry in spasticity in the right leg and left leg, Dr. Divya?
Sir, actually both are spasticity are present, but the right is more spastic than left, I found.
Yeah, that's very odd. The right limb is only involved. As of now, we are thinking that something is in the right leg, started from the right leg. Usually the degenerative disorder started symmetrically. That's an odd thing. That's in my mind. Otherwise, I'm agree with the all the experts and the seniors. Okay, we are dealing with some degenerative disorder. But usually it's not started with the focal features.
Yeah.
Okay, here's what sir says. Baldev sir.
I just wanted to ask the experts that we have looked at the child, and I just wanted on anthropometry the span. What is the span? And why am I asking it? And I want the eyes examined in detail. Lens, span more than the height. some arch
So,
problems in the legs.
yeah, though you means homocysteine.
Hmm.
So it's like a Marfan disorder. The morphology is like Marfan disorder, but there is a lens displacement in the homocysteinemia. That is, one is a posteriorly displaced, and in the Marfan is anterior displaced. Okay, that will be helpful, and homocysteinemia presented like this. Okay, so and the arm span is more than the height.
Is it a possibility in such children because they do present with weakness, these type of symptoms which
Yeah,
the
madam, but
child, it is
only thing,
against it.
yeah, against is that because there is asymmetry. Usually in homocysteinemia, you get displacement of lens in both eyes and loss of the arc and atrophy in the both leg.
Okay, so it's
And the
a little bit
spasticity is
symmetrical.
bit,
Hmm.
yeah, spasticity, speech involvement is again against the homocysteinemia.
And even they have some thromboembolic phenomena or some other features also common with this homocystinuria.
So that is why I'm asking you, are there
Yeah.
multiple thromboembolic phenomena happening in the brain,
Yeah.
happening in the spine, happening at, so because it's a patchy involvement, what the students have presented, whenever you have degenerative, they usually symmetrical affections of all four limbs. So are these multiple small embolic phenomena which are happening?
But madam, usually embolic phenomena will be very acute or some catastrophe. The child will be totally normal, a sudden weakness or something. I think here at any stage she has not described like that.
Are
So
these microemboli?
yeah.
Yeah, they're not becoming symptom. It's not a
Okay,
big impact
macroemboli. Okay.
because it's a homocysteine abnormality with to do with the blood uh, in the blood vessels and all.
Right.
Just thinking aloud, like because the
Yes.
patchy
When we don't have
involvement
the
is.
exact reason, we can give the various thoughts.
Yeah, but
I just
usually,
want to add here, basically, though the examination is showing some asymmetry, if we take go back to the history, the child had difficulty in walking upstairs to start with, and tripping and fall. They have not mentioned it was like a unilateral, means, so if it is a basically it is a bilateral kind of thing, then you have the difficulty in walking upstairs. It's more of a proximal weakness, right? And there was again, you mentioned the history of not getting into the sleepers, so that probably it was a bilateral again, right? The this thing. So again, in a whole picture, there could be some asymmetry, but overall, I felt that there was a bilateral involvement. Otherwise, the child would walk with a limping gait, right? So if it was a unilateral. So that was my thought to think about bilateral kind of condition here.
Can it be possible in a case of lead poisoning or so? Because which is also known for the peripheral nerve involvement, even the encephalopathy like, or even the central part involvement.
Yes, sir. Yes, sir. So lead can explain all the things because it can get deposited everywhere and
Because why it is coming to my mind, long back, we had one patient, very difficult to answer everything. And then one of my pathologist friends said that why have you not gone for the lead? I said it has not come to our mind. And then later on, we went for this workup and turned out to be this lead poisoning.
no, so
And it is known even to involve the peripheral nervous system also, even the central also, and even the spine also. It is known with these various involvements. So I think when we don't have the clear-cut etiology in mind clinically, I'm not sure whether the Divya has come with some workup and maybe the final answer with some investigations if she has. But I think should we go further if there are some investigations, Divya?
Yes, sir.
Okay, so please.
So that is a very excellent thought, sir. Lead can explain all the things which are.
I stopped Divya in between for this purpose of discussion. I thought that otherwise she may come with the final answer or something, probably that we don't have the point to think. Anyway, I'm not sure how much we have thought of, but at least discuss something. Now we can go further, whatever you have done. And
But what will you ask in the family history, household history? If you lead poisoning is a DD, then what should be included in the socio-economic and housing history?
The
I
father is
think our
painter.
mentor, Dr. Uday, is very silent, watching all of us. That's what we are trying.
Yes.
Actually, sir, the history-wise, if you see, the duration is 4 years,
Yeah.
which I think the points towards more of a chronological time frame. If we see, uh, all the poisonings may be there if it is like in the lead slow poisoning, but family history-wise, I think they can answer what are the points madam is pointing towards. But 4 year history with a progression which is very slow, it's point towards more of a like a degenerative problem. That is the what we can get from the history.
So you can just tell me the points in the history because that will help us to give a DD of lead poisoning.
The
One,
Kutch house,
yeah.
Pakka house. We can ask about the house condition.
Ishwarya, you are not audible.
Come close to the mic.
We can ask about the house, whether the house is Kutch house or Pakka house. The paint in the Pakka house, they will be using paint.
Father is a painter or not?
Yes.
The occupation of the father.
Okay.
Okay.
Water supply, the pipes, lead pipes.
Lead pipes. Okay.
Is there any industry in the
Neighborhood.
neighborhood?
And
Okay.
also, just to add one point, the toys basically, which are made basically in the Chinese toys,
Yeah.
there are reports that they are high with the lead content. So many a times there are few anecdotal case reports, those who are playing with the toys, plastic toys, mainly of Chinese makeup, it has a high level of leads. So that also the history we can ask.
So there is
Pica history is supposed to be asked, like if you have a younger child who comes like this. Yes,
there
sir.
there is one history in you have given us that indicate there could be a lead poisoning. What was it? You have given some.
Behavioral problems.
No,
Inappropriate laughter.
no. You
Peripheral.
mentioned that in your history.
How far you want her to go in the history, then one of them can go back. You have said it. So he wants it.
What was it? The child was on Ayurvedic treatment, right?
Yeah, yes. That is very important point. Very important.
So it contains heavy metals most of the times. I don't want to blame it.
Even it reminds me, Dr. Sandeep.
Yeah.
Already I discussed the case at multiple places. Patient which I got the lead poisoning. Later, I came to know from the dermatologist that child was on some treatment Ayurveda, and for the application over the lips for the leukoderma. And that was the very chronic containing the lead. And lips over, if you rub it, even very easily it will get absorbed. And even it can cause this lead poisoning.
Yeah.
So I think because now we have taken the other safety measures, these are some conditions which may cause this lead poisoning. So I think Dr. Sandeep has brought out very, very important point. May not be in this patient but I think for our learning, it's a very, very important point. Absolutely.
No, for this patient also, there should be very high suspicion for
Yeah.
Yeah.
I think the only thing why it came to my mind that very difficult to explain otherwise, but still we are not sure. Let us go to the presenters.
Yeah, again,
Ask history of Kajal, Surma, because they put lead in that, and girls say. So these are subtle questions which they don't feel important.
Yeah.
This has to come in the direct questioning. आपका जो बड़ा वाला list था ना, no history, no history. Usme this history you should highlight. Okay, we are all learning that.
And I think as a
But
lead,
madam, these points will come once the condition is in your
Yes.
mind.
Yeah.
Yeah.
So
so
now it is.
only one thing we also have to consider here, because this is only central nervous system affected. Basically, in lead poisoning, we get abdominal symptoms also, like
Yeah.
abdominal pain, constipation, weight loss is
Anemia.
also there, I think.
Anemia.
So it's not a
Yeah,
multiple
anemia.
system affection. Here, purely in the history also, we are getting CNS involvement. That is the one of the point actually.
No, I think there is one more pointer which again very important that mentioned in a history is inappropriate laughter. So there could be a behavioral or neuropsychiatric issues.
Yeah.
Which we need to go into detail because that also can imply towards toxicity kind of things.
Okay, you can go further with your presentation.
Dr. Dawal wanted to say something.
Yes, Dr. Dawal,
Yeah,
anything?
I am just wondering because the symptoms started and then they taken the treatment, Ayurvedic treatment. Am I right, Dr. Divya?
Yes, sir.
So it's again very difficult to explain on that basis
Yeah.
because the Ayurvedic treatment started after that.
After
So
that.
just keep in mind it may be responsible for the progression of the disease, but still we are searching for the acute reason. What is actual etiology?
So your point is valid. It may not be this case, but generally for learning.
By mistake, the residents keep the urine sample on the window sill and they forget to send it. And tomorrow, next day, they have a diagnosis. What is that? Huh? Neuropsychiatric problems.
Porphyria.
Porphyrias.
Yeah.
Okay. The next day, first the faculty will get upset with you for not sending the urine sample, but then when they see it red colored and you make a diagnosis by your forgetfulness, then you are the winner. Okay. Changes the color. So keep that in mind with neuropsychiatric problems.
So I think smart resident will answer madam next day that purposefully I kept it.
Yeah. It happened in BJ Medical College. So that is why I regret firing the resident, of course, because we were suspecting also urinary tract infection in that child. So that's why. But it turned out to be porphyria. It was a child from an orphanage and used to get abdominal pains, but used to have behavioral problems misinterpreted as. Okay.
Okay, go ahead.
And in the discussion, and we are differentiating the sensory ataxia with the motor ataxia. In location-wise, in the sensory ataxia will be affected the peripheral nerves or posterior column disease, but motor ataxia will be affected the cerebellar vermis. The gait in sensory ataxia will be wide-based, high-stepping gait. In motor ataxia, it will be lurching, staggering gait. On examination, in sensory ataxia, the patient sits normally, but peripheral position sense and vibration sense will be lost. But in motor ataxia, unstable to stay balanced sitting will be present, and it will be worsened by running and standing. And in sensory ataxia, as I already mentioned, there will be position and vibration sense loss in the extremities will be present. But in motor ataxia, it won't be present. And another one thing is, sensory ataxia, speech will be normal. But in motor ataxia, it will be scanning speech, and there will be ocular and limb dysmetria will be present. Going for the hints, in sensory ataxia, the patient often looks at their feet, right, to know their position. But in motor ataxia, a patient looks like alcohol intoxication. We have investigated our patient, and the routine and blood investigations were complete blood count and LFT, RFT, all the things were normal. And so we did our MRI of the patient. It shows the cerebellar atrophy. Here it is showing is present. And this is the report we got. There is cerebellar atrophy and subtle hyperintense signal in dorsal midbrain and middle cerebellar peduncle, likely suggestive of hypomyelination. And for the discussion, and we have put so many MRI findings, various conditions of ataxia. The first one is Dandy Walker malformation, which is present in the congenital. The MRI shows hypoplasia of the vermis, as here showing, along with the cystic like dilatation of the posterior fossa and also dilatation of the fourth ventricle. And the second one is acute varicella infection, where there is a cerebellar diffuse edema. Along with that, here it's showing the leptomeningeal enhancement along with atrophy. And here, hypoxic ischemic encephalopathy sequelae will get reduced. This hyperintensity shows reduced thalamus. Along with that, cerebellar atrophy is present. And in hemorrhages, various hemorrhages like mild, moderate, severe, are for over the period of time, they'll go for hyper intense and becoming atrophy. And in Joubert syndrome, we'll have molar tooth appearance here due to lengthening of the superior cerebellar peduncle along with cerebellar atrophy. And in ataxia telangiectasia, we'll get a cortical thinning. Along with that, we'll get fissuring of vermis will be present. And there will be cerebellar atrophy. Thank you.
Okay, can you stop sharing?
Just before you stop sharing, can you go to the MRIs again? Just if we
Yes, yes.
go to the MRI and we discuss the each case, whether that MRI itself fits into the our scenario, kind of how the things are. Suppose you get this Dandy Walker malformation. So can you tell us how that Dandy Walker malformation is going to present?
Sir, it will be congenital and there will be macrocephaly will be present at birth itself.
Yeah, so
Early
the
presentation will
symptoms
be
will be since beginning difficulty in walking and probably it doesn't fit into our presentation. What about acute varicella infection?
There is no fever, there is no rash for the baby.
So this is very acute presentation, right?
Acute presentation also there.
Next MRI.
Yeah, Dr. Sandeep, I just want to this chicken pox.
Yeah.
We have forgotten to ask that history. I didn't get it. But post chicken pox insult and then subsequently later on coming as ataxias. Because in the MRI, they have mentioned that the hypomyelination of cerebellum could be post insult. So was it something which was not noticed and it can leave behind us sequelae and then progress later on?
Unlikely, madam. Basically, what they have shown is a cerebellar atrophy, and
Okay.
the very interesting thing, which I think we need to go into the depth of it, is they have mentioned there's a pons involvement, and we were wondering why the motor involvement was in the lower limb only. So that signal, the hyperintensity, because it is not a myelination kind of thing. So probably there is a hyperintensity which is there in a pons and midbrain, which can actually give answer why she's having hypertonia, spasticity, and also has a patchy involvement. So that the question which was there, why she was having patchy involvement, could be because of the patchy involvement of the midbrain and pons. So that I think that finding we need to go into the details, what exactly it is. Otherwise, if it is a post-varicella involvement, it will involve only the cerebellum and it won't involve the other areas.
And I think, is it so, Dr. Sandeep, that post-varicella cerebellitis, what say, it's a inflammation following the immune mechanism, and it settles down or goes for the problem. I think most of the patients, they do recover very nicely without leaving any sequelae.
Exactly, exactly.
Fortunately, now we don't get the more numbers of patients, but in the past we had many patients of post-chickenpox cerebellitis.
Yeah.
Yeah.
Only,
And
I think, only if there is a vasculopathy. So if there is a vasculopathy, there could be some sequelae, but
Right.
most of them, as you said, should recover.
And post cerebral post chickenpox ataxia presented down the line to 1 year. So it may present, means past history up to 1 year is very important. So history of chickenpox before 1 year is also very important.
Okay. Anything else, or she should stop sharing?
Yeah, one more thing I want to add in this case, all the differentials he considered, but one more important thing we need to keep in our mind is mitochondrial
Just you
disorder.
stop sharing so that we can talk in details.
Yes.
Yes, stop sharing. No problem.
Yeah, Divya and Aishwarya, one more thing I would like to add in this case, in your differential diagnosis is mitochondrial disorder. Okay, so mitochondrial disorder may presented in a patchy ways. Okay, like for example, the MELAS. Okay. Certain mitochondrial disorder having an involvement of the hearing and the optic nerves. Okay, but certain mitochondrial disorder presented like this. Okay, so there is complex 1, complex 3 deficiency. Okay, and it may be progressive disorder. So keep in mind the one more thing is a mitochondrial disorder in your differential diagnosis. I think so, Sandeep. Anything else you want to add in differential?
No,
Because CDG is very rare. That is a congenital glycolysis defect.
Yes, mitochondrial is a good possibility again. So because of the multiple systemic involvement, so the cortical involvement, cerebellum involvement, peripheral neuropathy. So mitochondrial disorder is always a differential. Obviously, it is difficult to differentiate on examination itself whether something is mitochondrial or not, and requires investigation. But here you, on a MRI, at least you have got a very good cerebellum involvement, cerebellar atrophy. So I think one of your hypothesis was spinocerebellar ataxia. So in that kind of thing, we need to go into the details of that, whether it fits into that hypothesis or diagnosis.
You mean to say genetic?
To the experts, if they can help. Is there any familial some cerebellar atrophy or so? At least I have seen in the past 2 children having this cerebellar problem, and that was I think some syndrome. Which syndrome or something is there?
Joubert syndrome.
Able to
Yes,
recollect?
Joubert syndrome.
Where the multiple, even the children from the same family can be affected. They can come even later on. And the MRI findings may show the cerebral some atrophy or so.
There are so many. That is ataxia telangiectasia. Then the OMA type, that is a oculomotor apraxia, type 1, type 2. There is autosomal recessive cerebral atrophy also. They usually start around the 4 year of age. Okay, and it is chronically progressive. And in our case also, it might be possible because the peripheral nerve system involvement as well as the ataxia, and later on the cognitive deficit also. Okay, that syndrome knows start from that ARCA something. I will just give you name. I'm not able to recall it, the name. That is autosomal recessive disorder. Okay.
Okay. I think should we go for some genetic study? Can it be helpful?
Sir, actually we have sent exon sequencing.
Okay. So at least Divya, when you get the answer, please let us know so that we can learn.
There are some rare conditions where you have leukoencephalopathy with cerebellum and basal ganglion involvement. The genes have been identified actually. It's hardly some 11, 12 cases have been reported. Our experts may be able, but it explains your patchy involvement, genetic etiology of it, and you have cerebellum and basal ganglion with leukoencephalopathy, like means the cortical involvement also. So everything is involved. And if this same child, sir, if it was an adult, and slowly progressive degenerative disorder like this are your motor neuron disease. So they are more of adult disorders, but do they occur in children from say 7, 8 years onwards? The motor neurons from CNS, upper motor and
There is
lower.
there is a motor neuron variant in pediatrics, so but it usually seen around adolescents like 12 to 14 years, which is known as Hirayama disease. So it is more of an anterior horn cell involvement. And probably again that patchy involvement which we see maybe you can see in anterior horn cell, but again the cerebellum involvement goes against it. And the second thing, the other thing which comes to my mind with a patchy motor weakness is your polio kind of disorder, or maybe enterovirus myelitis. History of with fever, it can present with weakness which is asymmetric. Again, it specifically involves anterior horn cells, so that that can be a possible. But here we have more systemic involvement, like it's not localized kind of weakness. So probably generalize some kind of disorder like speech is also involved. So that goes more into degenerative disorder. I think we need to, because with the MRI, you have ruled out demyelinating disorder. So there is no demyelination, dysmyelination. So you left with a degenerative disorder. Mitochondrial is still a possibility sometimes, but if you go to the genetic route, probably you may end up ruling out mitochondrial disorder as well.
Yeah,
What
Baljan sir,
about the Wilson's,
that
neuro Wilson's?
Neuro Wilson, madam, usually having carefree. It's not always required the liver presentations, means hepatic failure first, but they presented usually with the dystonia. Here the presentation is the spasticity. That's again in our case. And the KF ring is, we can see KF ring in naked eye also, but here the ophthalmic examination is normal. Okay.
Second thing
Yeah.
for this
And
CNS manifestations is a little bit early. Usually CNS involvement in Wilson is older children, 7, 8 years
yeah.
or 10. And then the mainly extrapyramidal system involvement, dystonia or tremors, or even changing the handwriting. So many things. Even the KF ring may be the obvious, as Tawal said, absolutely.
Sir, what you asked now, that syndrome known as a autosomal recessive spastic ataxia of Savrolic and Sanguine. That is a ARSACK. It's very difficult, so I'm not able to get it. So I'm just
So this is
search from the net. That usually presented in this age group, having cerebral ataxia, pyramidal tract involvement, and peripheral neuropathy.
right.
But hallmark is that there is a hypermyelination in retinal fiber. So ophthalmologist friend will help us in this case if there is a hypermyelination. Okay, that observed in fundoscopic examination. So it is at late onset and usual age is this, and that is a SEC gene that is responsible for this condition.
Spastic attacks.
Yeah.
Okay. Anything, or should we end over here?
Yes, sir.
Or
We
another-
have 5 minutes. If want to sum up the case, sir, what you learned today, the students can tell us.
Yeah.
What did you learn today after the session? You all presented, but what did the experts, Dr. Prajapati, sir, what is the take-home message which will improve your presentation and also the approach to the case?
I think first, let me appreciate both of them.
All right. Yeah.
Definitely, they have, I would say, taken the good history. And all of us know that it's not so easy for any person, that to even after 2 or 3 years in the field of pediatrics. They could see us that after so many years here, we are not able to discuss to the point or precisely. And for that reason, I think they have done the very good job. But another point which I will appreciate that they came with some videos. This is good, because what happens that on these type of the virtual discussion, we are not able to see the patient, what exactly the sign is there, or DTR or something what they were showing. So I think if we come with these videos in the future, I will request the other presenters in the future that they should come out with some photographs showing some sign, or even this type of video, so that we can have real interpretation, understanding that exactly what type of the problem with the patient is. So it's a good thing in this type of presentation. Second, I think for that workup also, but what usually I will say that the end of history, always try to perform the habit of summary. And that summary should not be a repetition of all the points which already you have discussed. That summary should be, I will say, few sentences. That what is your hypothesis? What you are thinking, is it serious problem or something else? Which serious, what is the likely anatomy, which part is affected? And then what is possibility, the infected or infective vascular or something? And then what are the various possibilities which can come? Even possibilities may not be you can put forward in the history. And then examination, I think always first put the examination findings appropriately. That what are the positive findings starting from the higher functions to cranial nerves and all the points, only positive finding. That should create the very clear picture in your mind that which part of the CRS is affected. And so that we can have the, I would say, clarity of the thought process. At the end, even many times somebody is asking this also from the history, that what you are expecting on examination, whether there is the hypotonia or hypertonia, whether deep tendon deflex normal or in some other way. What are the plantars? Because according to your thought process, that means what you are expecting on the examination. And suppose something beyond your expectation, then it indicates that we have to go back to the history, something we have missed. So retrospectively, even we can go sometime to the history, which was not, suppose already came to our mind that lead poisoning or some degenerative or something. Then later on, we'll go to the history part, which probably are not included initially. And that is also good way of presentation. Even you can add later on in the examination that this was not in my mind. Later on the examination, the thought came to my mind, and retrospectively I confirmed the history. So that of the presentation also is brilliant many times in the examination that you can keep in mind. The point is your methodological thought process should be there. Diagnosis is never important. On the contrary, knowing the diagnosis creates the problem. So I think it should not be our focus. Of course, with the presence of experts, all of us learned a lot that how we can go for the various thoughts, even beyond general pediatrics, what we are thinking. And that's, I will say, the beauty of this discussion, that the presence of multiple teachers, experts, not only the students, but all of us are learning. And definitely, Dr. Sandeep and Dr. Dhaval played a very important role in understanding the situation. Of course, as I told that our mentor, Dr. Uday, must have played the major role. I understand the teacher's role is always major, to prepare the students. And what the students were speaking, it was the reflection of the teacher. Always, naturally, the students by their own may not be possible to come out with all these informations. So of course, what I am gradually learning with even these type of the virtual discussions since many years, that all of us are learning from each other, and that helps a lot. Thank you very much or other friends to speak or to some comments, and then we'll end over here. Madam, over to you.
Thank you so much, sir. I think this summing up is always expected from you. That session doesn't end without that. And special thanks to Dr. Dhawal and Dr. Sandeep. I know it is Saturday, but you all have added many points which probably we would not even realize that we should be adding that to our general pediatric case presentation. So both the girls have presented it very well with under the guidance of Dr. Uday. So I thank you all. And there were participants who did participate in some discussions. So keep it lively. Next time, more participants can ask questions. Actually, you put it in the chat box, or you can, we are sharing the faculty link with you now so that more people can be on the screen rather than on the YouTube links. So please take the advantage of all these specialist experts who are coming. So we will end the session here, sir, with special thanks to also Dr. Yogesh Parik, sir, and Dr. Nehal. Now they are very active members of Central IAP. So we should thank them for giving us this platform while they are busy with the coming up Pedicon next week. So we'll see some of our faculties and experts over there. So thank you very much, everybody, and special thanks to Dr. Baldev, sir. So we close the session over here, and we'll meet next Saturday with some more experts. And what I enjoy is like the students like Sandeep who have been with us are on the specialist and experts platform. So it's a great joy for a teacher. I think Dr. Prajapati sir will agree with me that when we see our own students over there, it's very satisfying. All right. So one day the two girls will be on that side also. Okay. All right. Thank you, everybody, and have a nice weekend. Thank you. Good night.
Goodbye.
Thank you. Good night.
Bye bye.
Bye.